now. Okay, I hope that that you can see that, and thank you for the introduction and for the invitation to come and speak here. And I've just been very interested following what Antonio and Luc were saying about in relation to the research that they've been doing. So I'm coming from a different level. They spoke about the genomic level, the protein level, and I'm moving to the population level. But one thing I would say that links all these three is that what we would argue would be for the primacy of data. And no matter what level you're working with, you have to try and get two things right. You have to try and make sure you're measuring what you need to measure, and you have to try and control for the things you don't necessarily want to confound the data. But just again, thank you very much for the opportunity to be here, and good afternoon here from Ireland. And just to let you know, as Shafi was saying, I'm a consultant in public health medicine and medical epidemiologist in the National Health Intelligence Unit, which is part of the HSE, the Health Service Executive here in Ireland. And one of our philosophies really is to try and use routinely collected data as much as possible. And what we try and do is we try and overlay data from one source onto data from another source. So there are always issues involved in that. And we then try and map it. We try and I suppose display it in a way that is visually appealing or that is visually makes sense. And then we try and disseminate that. So there's an educational element, there's a kind of dissemination element, there's definitely a strong communications element in that as well. So really, hopefully what I'm going to be able to do for you today is just tell you a brief story about what we came up with in relation to material deprivation and the COVID outbreak, the first 3 waves of the COVID outbreak in Ireland. If I can just get this to kick off. So really, a lot of the discussion around COVID and about the way it impacts on communities and on populations, we tend to look for historical context to the influenza pandemic in 1918, 1919, following the Great War. Initially, because of the fact that it affected so many people at so many strata of societies, the influenza pandemic was called the Great Leveler. And this was, for many ways, this was associated with massive human movement, with massive deprivation, with massive exhaustion after the Great War. So it seemed to be something that affected people at whether you were rich or poor, whether you were you lived in a big house or a small house. It seemed to affect everybody. That was at the beginning. It soon became quite clear that there was a disproportionately greater impact on poorer populations, and this was one of the reasons the waves kept coming and coming and coming, because there was this impact on poorer populations, and particularly on migrant populations, on people who've been traveling, on people who had been marginalized refugees, or who had been affected directly by the war, by bomb damage, by troop movements. So this was a huge impact, but certainly the impact was greater in the poorer populations. And one thing that struck us all, I think, when the COVID pandemic struck 101 years later, was the first lines that came across: we're all in this together. This is something we all have to take on the chin. This is something we're all going to be part of. And certainly that seemed to be the case in the first instance. But were we really all in this together? Was this something that everybody suffered to the same extent? Was this something that everybody felt the same impact from? And I suppose what we wanted to do then was to look at what was happening in other parts of the world, thinking that, well, maybe it's not that equal. And we certainly saw, and I'm using specific examples here, early reports from New York, from Canada, from the UK, that deprivation was a major impact. It played a major impact in terms of poorer COVID outcomes for huge areas of the population. So just to go into that in a little bit more detail, one of the first papers was related to COVID deaths in New York. And one of the things that they determined was that in zip codes where a third of the population lives in poverty. Early COVID-19 death rates were 232 per 100,000, and New York, as the world knows, was one of the very early impacted areas, one of the very early impacted regions, as were many of the big cities. In more well-off neighborhoods, I beg your pardon, where fewer than 10% lived in poverty, death rates were less than half that. So this was early, an early kind of a heat map that was generated to show that not everybody is in this all together, and that you could overlay, for example, a COVID death rate map on a deprivation map and find that there was a huge degree of overlap. So just moving on from that, one of the things that the mayor of the time, Bill de Blasio, said was that the deaths might have been prevented if there'd been more attention paid to some underlying conditions such as diabetes and hypertension. But again, those tend to be more prevalent in low-income communities, and things like overcrowding, generational overcrowding, particularly in kind of very built-up areas. These would also be associated with increased transmission and increased transmissibility. Now, this study was one of the first that actually indicated that it might not just be deprivation, but minority ethnicity might also play a big role. And I think that this is a theme that then comes back in terms of some of the early Toronto reports. So first of all, of course, that the same kind of pattern was found in poorer neighborhoods such as York University Heights, 900 cases per 100,000 population, and then in more affluent neighborhoods, Banbury, Don Mills, hugely reduced, 87 cases per 100,000. And again, part of the almost unspoken coda to these surveys, to these early studies, were that areas that were more materially deprived also tended to have a greater preponderance of people from ethnic minorities, and it became difficult to kind of tease those out and see which actually had the greatest impact. So one of the caveats, and I think this is brought up in the Toronto paper, but it's also one that we were deeply aware of, was disease mapping. It shows where infected people live, not necessarily where they acquired the disease, but where they live. They take with that the kind of the imprint, the socio-demographic imprint of that wherever they go. So, for example, if you're living in a deprived area, you are, I suppose by token of the kind of the Irish metrics, you'd be less likely to have finished secondary school. You'd be less likely to have a college degree. You'd be more likely to be working in a kind of more lowly paid job, and these would be characteristics, if you like, that you would take with you wherever you go. So the fact that it indicates where people live isn't such a bad thing, but it's just something, again, to be aware of. And the other thing is, and as anybody who's studied the kind of population impact of COVID-19 will know, some of the major impacts in the first instance were in congregated settings, particularly nursing homes. So these were also taken out of the individual's usual address. So an individual might be from a very deprived area, but move into a nursing home in a less deprived area, or be from a very affluent area and move into a nursing home in a less affluent area. So again, those kind of caveats are important to remember just in understanding the data and in understanding how to interpret them. And some of the best research and some of the most telling research has come from our neighbours in the UK. And I think one of the big things that they found there was COVID-19 mortality rates in people under the age of 65. And I specify under 65 because the rates over the age of 65 were almost they were so high that they almost kind of outstripped other factors such as deprivation or comorbidity. But COVID mortality rates in the under 65 were nearly 4 times higher in those most deprived areas compared with the least deprived areas. So again, just to see this kind of patchwork map, Southeast Scotland, for example, reported places like Renfrewshire reported up to 74 deaths, I beg your pardon, per 100,000. Northwest England, particularly the areas of Liverpool, 22 per 100,000. The West Midlands, Birmingham, the kind of the Birmingham area, 21.7 deaths. London, 25.5 deaths. You can't really see it from this map here because you would need a higher definition. It looks, if you like, the deprivation, the greater the color, the darker the color, the more the deprivation. London looks like a less deprived area, but of course, like most cities, there are very, very focused areas of deprivation. It's just that the map, unfortunately, doesn't have the definition to be able to show that. South Wales, another hotspot, 44.5 deaths. But in the kind of the more the kind of the home counties and in the southeast and southwest of England, the deaths were 6.4 per 100,000. So a factor of 10 could make a difference between the southwest of England and the southeast of Scotland, for example. So as far as the kind of the original, we're all in this together, it certainly seemed that that wasn't the case, certainly in other countries. Now, one thing that we were very interested in when we were looking at this was saying, well, would the Irish context, would we find the same patterns, the same very large deprivation gradient that other countries have? And again, the subtext to that is it was very difficult in particularly the US and Canada and in the UK to separate the impact of ethnicity and the kind of minority ethnicities and that the association between minority ethnicity and deprivation. It's very hard to tease those out. In the Irish context is we tend to be a more homogenous society. We've had a lot of immigration the last 20 years from various parts of the world, but we are demographically unique because we have a small population. The reason our population is so small is that in the 1850s, with famine and emigration, half the population either died or left the country. And to be perfectly blunt, we still haven't actually managed to reach our population level, which was there for the 1851 census. So we've spent 150 years trying to build our population up again. So we have a small population. It has been racially and ethnically very homogenous, and it's only in recent years that we've begun to develop that kind of diversity that other countries have experienced. So that, again, that's just an interesting point to be aware of. So just in terms of how it impacted Ireland, the same way as everybody else, it was we had 1.5 million total cases by the 18th of May. So this is in a population of just over 5 million. 7,244 total deaths by 18th of May. And the timing of this, really, we wanted to kind of look at these figures before the vaccination program really kind of kicked in, but also to include the wave 3. So what we wanted to work out was for those kind of, particularly for the early waves, were outcomes worse for those from more deprived populations? And did the Irish experience mirror or match in any way, shape or form what had happened internationally? So what we did was it's a retrospective cohort study of routinely notified COVID-19 cases. So what we're doing, again, we're looking at routinely collected data. These are notified through PCR and recorded in the National SIDE, or Computerized Infectious Disease Reporting System, for which we owe great debt of thanks to our colleagues in the Health Protection Surveillance Centre, who are partners with us on this research. All cases that we examined were notified between 1st of March 2020 and 13th of May 2021. And as I say, we wanted to choose that kind of that tranche to try and identify cases that happened before the vaccination system really began to kick in. So we georeferenced all cases to geographical small area. Now in the Irish context, our geographical small area represents between 50 and 100 households. So it gives a very granular picture, and each small area carries its own deprivation index. So what we're able to identify the number of cases happening in a geographical small area, a specifically defined region of the country. And we're also able to determine what the deprivation index is of that. And I'll just go into a little bit more detail about the deprivation index in the next slide. So pandemic timing is represented in waves. So wave 1 from 1st March 2020 to 1st of August, wave 2 from 2nd of August to 21st November 2020, wave 3 really kicked off after that, went over Christmas 2020 to the end of our study period, 13th of May 2021. And again, these are nationally accepted dates from our partners in HPSC. And we looked at 3 outcomes, and we wanted to compare those by deprivation index: hospital admission, risk of hospital admission, risk of ICU admission, and death. And these are obviously, these are proxies. Hospital admission doesn't necessarily give us the incidence because not everybody who got sick was admitted to hospital. Complication rate, we used ICU admission as a proxy for complication rate, showing the seriousness or progression of the disease, and death, of course, the hardest endpoint there is, and one that I think was very much it was very important for people as a metric to follow, because people could use that to determine the death rate, the flattening of the death rate, to determine how the pandemic was progressing. The deprivation score is a 5-unit score. It's based on the 2016 PUBL HP deprivation index. Now, just to explain that, PUBL it's a national agency. It's a part of the public body that looks very much into poverty, environmental and socioeconomic benefits. The HP stands for Hasse-Pratschke. It stands for Trutz Hasse and Jonathan Pratschke, the 2 scientists who determined the deprivation index. And they use a Central Statistics Office, CSO data, to use factor analysis to calculate a deprivation index for each small area. At the moment, that's based on the national 2016 census. There was supposed to be a census in 2021, which was deferred because of COVID. The 2022 census is being analysed now. We'll be up on our own local health atlas, and we will be developing a 2022 PUBL HP deprivation index. But for the purposes of what we're doing at the moment, we're using the 2016 index. So the HP index, the Hasse-Pratschke index, our deprivation index, identifies 3 dimensions. Excuse me, just trying to move my sharing tray here. The first one is demographic profile. So obviously there's age, and there's it would be a major part of it. Social class composition includes occupation, education, and there's labor market situation, employment, unemployment, or the kind of third university level qualifications, that kind of thing. So there are, I think, 19 different factors, all derived from our census, that factor analysis is used then to calculate this index. This index is then applied to a small area, and so we then map that small area as a unit with the numbers, the rates of COVID happening within that small area. So all the data we have is anonymized, it's aggregated, and for this reason, we believe that it can be readily shared, and we like to share this data as much as possible. But this just gives you a visual clue as to the HP index. It's your population, your bell curve. In the middle, HP3, neither affluent nor deprived. Our default color tends to be yellow in our maps. HP2 is more deprived. That's more than 1, but less than 2 standard deviations below the mean. And more than 2 standard deviations below the mean is HP1, is the most deprived. And on the other side, there's more affluent and most affluent. So in general, red or brown tends to, on our maps, tends to relate to deprived, and blue or dark blue tends to relate to affluent. And I'll just show you a few examples of the maps towards the end. So the time frame, these are our 3 waves, and again, very familiar with everybody else. The wildvirus predominantly for the responsible for the first wave, and the kind of the segue into the second wave, alpha variant in wave 2, and the delta variant in wave 3. So as I say, we're taking this up to May 2021 to try and reduce as much as possible the impact of vaccination. And the fact that vaccination was freely available for everybody in the country would tend to make it, if you like, more democratic, and therefore we wouldn't necessarily be able to apply the same kind of deprivation mandate to the data subsequently. So just in terms of deprivation and incidence, again, sorry, I'm going to move this share tray a little bit. This is, if I can show on the top, we show COVID-19 incidence by affluence or deprivation by age group. So red is deprived, blue is affluent. And on the bottom, we have the COVID-19 affluence deprivation rate ratio by age group. So we can see that for both really for both incidence and for the kind of rate ratio, the reds tend to be higher than the blues. So what we can say is really across all age groups, with one exception, which I will draw your attention to, and across all waves, the rate ratio for incidence was higher in the deprived groups compared to the affluent groups. Now, in the 20 to 39-year age group, almost consistently across all waves in age group, that showed a greater risk ratio towards the more affluent. So I can just show it to you here for all of these cases, the blue is higher than the red, which was one thing we found was interesting, was unusual. And again, I'll kind of discuss that towards the end. But for every other age group, for every other wave, for the incidence and risk ratio, rate ratio metrics, we could see that there was a deprivation gradient. Now, it wasn't enormous, but it was there. But just in terms of the three outcomes we're looking at, first of all, hospital admission. And again, I'm just going to flag a few major points from this. Admission to hospital was associated with increasing age. So we could see that kind of the big cutoff, basically by the time you got over the age of 50, your risk of hospital admission was increasing to 2.7. By the time you're 80 plus, you're 13 times more likely than someone in the control group to be admitted to hospital. Comorbidity, 3.27. We've had multiple conditions associated with it. This is something that was very much going to be associated with an increased risk of hospital admission. And again, we saw a relation between hospital admission and deprivation. So HP1 and HP2, deprived and very deprived group taken together, your risk of hospital admission was 1.22. 95% confidence intervals varied from 1.15 to 1.28. So the risk was there, it was statistically significant, but how clinically significant is it? It's certainly not a very big gradient. But that's just the kind of the first indicator, if you like. Then we move on to the ICU admission. And again, as I say, we were taking this as a kind of a proxy for complications. And again, it's the model table we have. And we saw the ICU's admission, was associated with increasing age. And again, we can see that particularly in the 40 to 49, your risk goes up from 1 to 3.63. Increases hugely to 70 to 79 to 9.67. So you're nearly 10 times more likely in your 70s to be admitted to ICU compared to your 0 to 39. But interestingly, at 80 plus, the risk of admission to ICU goes way down. Now, this may be a point of view of the kind of discussions that were happening early on, and trying to, if you like, to curate admissions to ICU, and somebody, possibly a much older person who might be admitted to ICU, there may be less likelihood of weaning them off a ventilator, and they might be seen as less likely to benefit. So there could be clinical choice in there as well, as opposed to just kind of epidemiological risk. But again, largely speaking, increasing age associated with the increasing risk of hospital admission. Again, comorbidity. Interestingly, the kind of the comorbidity was gave you overall a less likelihood of the comorbidity was increasing likelihood. Wave of pandemic, you're less likely to be admitted in wave 2. Comorbidity, you were much more likely to be admitted. You're 30 times more likely to be admitted to ICU if you had certain comorbidities. But again, pandemic wave, there was another thing. So the patterns we tend to be seeing here are age and comorbidity. If we look at deprivation, really for both deprived and affluent, they both cover the null value of 1. So there really wasn't a link between deprivation and hospital ICU admission, I beg your pardon. And just the third model really is mortality. And again, just the model values there. And mortality, we could see there was associated again with increasing age and hugely so, going from 6 times in the 40-year-olds, 14 times in the 50-year-olds, 66 times in the 60-year-olds, and nearly 500 times in the 80-year-olds. Like this, this was just an enormous amplification. Comorbidity, again, 10 times more likely to die if you had comorbidities. And interestingly, pandemic wave, highest in pandemic wave 1. But again, deprivation, they're really both the HP1 and HP2, the more deprived, and HP4 and HP5, the more affluent. Both of those include the null value. So these were not significant. There wasn't a significant association. There was a weak association with gender, but again, that was probably clinically too small to really discuss. So again, this is, as I say, this is just very much a bird's eye view of this, but what we could see is the risk of being a confirmed case of COVID was higher among more deprived categories for all ages across all 3 pandemic waves, except for one age group in which the reverse pattern was found. And maybe now's the time to kind of address that, because as I mentioned earlier, we have a small population in Ireland. One of the biggest employers is the health service executive, and that employs a lot of people in that 20 to 39-year age group. Many of those were in the front line. Many of those were at greater risk of developing COVID. So we feel that there is, if you like, a kind of a demographic reason for that, and very possibly associated with the numbers of people in that age group who were front-facing, public-facing, in the health services, in emergency services, but also in jobs like, for example, stacking shelves in supermarkets, in providing the kind of the emergency services, the kind of services that everybody needed, even when people were locked down and unable to, for example, attend work because their office jobs when schools were closed. These are the people who were keeping society going. And certainly in our country, the majority of them were in that 20 to 39-year age group, and they were at very much greater risk as well. So we believe that that's a kind of a demographic glitch almost in the Irish population. So this also, because so many of these were in the health service, we believe that they required serial testing. So this is the possible ascertainment bias. And we're not saying anything new or anything outlandish, in knowing that comorbidity and an increasing age were consistently associated with all 3 outcomes, with hospital admission, ICU admission, and death. And there was only a deprivation gradient that we could see in our 3 models with hospital admission. We saw that there was with incidence, not a very strong not a very strong gradient, but there was a gradient there for hospital admission. But again, it's not a very strong one. And we believe that overall outcomes tended to improve in later waves, and this is possibly due to increased understanding and management of acute cases. So maybe the best data is there from wave 1 that kind of understands, maybe gives us more to chew on in terms of population characteristics. Now, one thing I do have to say is we could only include PCR positive cases in the analysis. So we're not able to comment on anything that might have been observed by including PCR negative clinically suspicious cases. And that is certainly, that's a drawback. But again, I think that what we have is certainly something that's interesting. But I did want to just discuss briefly the fact that we found a small deprivation gradient for incidence and hospital admission, but not for outcomes. So this is at variance, at a certain degree of variance with what other countries have experienced. So I just wanted to maybe look at maybe the distribution of deprivation in Ireland and consider whether that might have played a role. And again, this is something, these are questions that we're continuing to consider, and we're continuing to apply in terms of other infectious diseases and other chronic diseases, and the whole concept of marginalization, of ethnicity, of health inequalities, of deprivation, and kind of gender inequalities, racial inequalities, disability inequalities. These are areas we're beginning to look at. But in terms of deprivation, we tend to have a very scattered Jackson Pollock type picture of deprivation in Ireland. Most of our deprivation is not actually in the cities. Most of it is in the countryside, particularly in the west. And we can see there the blue areas are the more affluent areas, are more affluent. The brown and red areas are more deprived. But just for example, in Dublin, if we kind of zoom into Dublin, we can see again this patchwork quilt. There don't tend to be any large areas, large kind of voluminous kind of cross-city areas of great deprivation, and they tend to be clustered close to areas of affluence. The same, absolutely the same in Cork. There are a few areas, of course, of urban deprivation that have their own specific problems, but they tend to be very localized, and they tend to, if you like, to borrow hugely from more affluent areas that border them directly. Same in Galway, a few areas of urban deprivation, but surrounded by areas of more affluence. But I suppose places in the west of Ireland, particularly like Donegal, these are areas where you would see deprivation, and it tends to be isolated, it tends to be rural, and it tends to be further away from the cities. So whether this demographic picture can help to explain why we haven't seen the same picture we've seen, but it also might be, and it might be, there may be an association with our racial homogeneity. We didn't see the same kind of poor outcomes in an Irish context that other countries have seen. We saw a mild gradient with incidence in hospital admission, but not with ICU admission or with Germany. There are a number of other European countries that suggested that earlier cases tend to be more affluent. And certainly in Ireland, we saw that the first cases we saw were school children coming back from skiing trips in Italy. And Italy was certainly the epicenter of the early pandemic in Europe. So we tended to see impacting more affluent urban areas in the earliest weeks and months of the pandemic. As I mentioned, we have a more ethnically homogeneous population. We don't tend to have the same kind of structural marginalization or ghettoization as other countries have. And again, because of our small population and because of our own kind of demographic uniqueness, I suppose, it may be greater social equality. How do you define that? How can we explain this going to the future? And what can we learn about the way we manage the way we manage infectious diseases and chronic diseases as a result? So we're calling for more research into deprivation and its impact on COVID, but also to expand that to look at other infectious diseases, but particularly to look at chronic diseases, but also to consider the impact of ethnicity, of gender, of disability, and all of the other factors that impact on health inequalities. Our study suggests that I suppose on the face of a superficial reading of it, there tends to be some truth in the saying that we're all in this together in Ireland anyway, but we want to find out why that might be the case. So we do want to be looking much more closely into this. So I am happy to finish it there, and I'm also more than happy to take any questions or to take any ideas as to where maybe future research might take us. And thanks very much indeed for your attention.